Hi everyone. Having discussed the happy mnemonic of the DNA viruses, we have one virus called the Hepadnaviridae which comes under DNA because it is hepatitis B, and all the other viral hepatitis that we have come under RNA viruses. So I've got this as a transition chapter between DNA and RNA. So we'll take up all the hepatitis. And also I had promised all of you in the pathology lectures that I will be teaching you hepatitis as a whole. So right in the end, I've got you a couple of pathology slides so that now you just have to read hepatitis over here, and this takes care of your entire path as well as micro in one lecture. So because I'm dealing with both subjects in the same lecture, I would say that hepatitis is many types. Number one, there is something called viral, which I'm going to focus on more. But what I've already taught you in pathology is the alcoholic hepatitis. Then we've also studied the non-alcoholic steatohepatitis. These have been covered. We have studied autoimmune hepatitis. Remember, emperipolis is very important, done. And finally, in neonates, it becomes neonatal hepatitis. So my concern over here will be viral, and we know primarily we are going to go from hepatitis A to E, and then I'll tell you hepatitis G also. So first, I think what I've already been telling you, that hepatitis B is the only one that is going to be Hepadnaviridae, matlab DNA virus. Rest all of them come under RNA. This much information you know. Now you need to know their families, and to learn their families you need a mnemonic out here, because I've realized that many students don't know the family member ka name, the main family origin. So hepatitis A, B, C, D, E you write in an order, and then you write the most accepted thing in our country, that private hospitals favor rich clients. Okay, so P is for Picornaviridae. Now I will be teaching you Picornaviridae in RNA viruses. It is also known as it has enterovirus, and there are many enterovirus, 70, 71, 72. So I'm talking about enterovirus 72 as hepatitis A. So P for Picornaviridae. Next one, H for Hepadnaviridae, you already know because this is the only DNA virus that you have. Then F is going to be for hepatitis C, that is Flaviviridae. F is going to be for Flaviviridae. See, hepatitis D as such is not an independent virus. It is something that is always dependent on hepatitis B. So with R, I have learned it relies on hepatitis B, right? And finally, the last one with C, that hepatitis E is going to be Calciviridae. Also, now it is said to be a part of the family Hepiviridae. Okay, so that is another update that you should be knowing. It's now said to be a part of the family Hepiviridae. Okay, so I've told you private hospitals favor rich client, Picornaviridae, Hepadnaviridae, Flaviviridae relying on hepatitis B, Calciviridae or Hepiviridae. Now let's talk about the mode of infection. I think the most well accepted point is that the first and the last, that is hepatitis A and E, are the only ones that have feco-oral route by which it comes. So I'll pick up these together in one group. Whereas all the others, especially B and C, are related to the parenteral, sexual and mother to child. So especially B is the one that is related to parenteral, sexual and mother to child. Hepatitis C is primarily related to parenteral. It could be that is related to blood transfusion, IV drug abusers. So parenteral se relation we have with hepatitis C. Right in the end, I know all of you are waiting for those things, which is the most common leading to chronicity, carrier, acute, and I've got a final flowchart right at the end where I've summarized everything. So no point confusing you with those sentences in between. End we'll make a chart and sort it out. Okay, now talking about their incubation period. So simple. The ones that are going to have a feco-oral route, that is hepatitis A and E, will have somewhat a similar incubation period of 15 to 50 days. Easy to learn. The feco-oral route wala, gastroenteritis wala, 15 to 50 days. The other ones that you have in between are again some similarity you will have to find. So hepatitis B and hepatitis D, because they are usually very much dependent. So 50 to 150 days roughly. And then thoda sa kam kara, so 15 to 150 days for hepatitis C. You might get a variation in many books. I've tried to make, rounded off numbers so that you can learn it in a more easy manner. Kuch books mein 45 days hoga ya kuch, but that becomes difficult to learn. Na? So simple to learn is the ones with gastroenteritis are 15 to 50 days. And uske andar, if you make it a little more, the hepatitis C becomes 15 to 150 days, whereas 50 to 150, 50 to 150 are hepatitis B and D, which are dependent on each other. Okay. Now, let me start off one by one. Before that, let me just give you a brief table about which are enveloped and non-enveloped. I think I told you all of the viruses are going to be enveloped, but do you remember the gastroenteritis ones are not enveloped? So basically, the ones that don't have an envelope are A and E. Remember a mnemonic called PARCH? Yes, which are the non-enveloped viruses. Non-enveloped may we had PARCH, and A and hepatitis A and E were not having an envelope. Okay, which out of these is cultivable? Only and only hepatitis A is cultivable. Only and only hepatitis A is cultivable. For which of these do you have a vaccine? Almost for all, and I'll tell you how. A and E ka to gastroenteritis wala vaccine is available. Hepatitis B ka vaccine is there, and since D is dependent on hepatitis B, so if B ka vaccine is given, the protection for hepatitis D is also sorted. Basically, I say that hepatitis C does not have a vaccine. And why does it not have a vaccine? Why couldn't I make a vaccine for it till now? I will tell you shortly. But broadly, you say everyone has a vaccine, including D also, because if you give vaccine for B, D ka coverage ho jayega. But C has no vaccine. Now let's talk about which of them is fulminant. So remember, D and E ka fulminancy is very, very important. Others, if you want to learn or don't, you can see the ratio is 0.11%. So I would prefer not to learn only. I will say that in dono ko yaad rakho. So what can you see? Which is the most common cause of fulminant hepatitis? The most common cause of fulminant hepatitis is hepatitis D, because I see the percentage right in front of me. However, if they change the question to the most common cause of fulminant hepatitis in pregnant ladies, and that is gonna be hepatitis E. Pregnancy mein 20% is written. If I actually tell you what, something which is not there in textbooks, but journals mein aa chuka hai, 25% is actually the fulminancy thing that you have to know. So reach out for the question. Most common cause of fulminant hepatitis, hepatitis D. But the most common cause of fulminant hepatitis in pregnant women, that is going to be hepatitis E. Now talking about the chronicity. Which are the ones which are going to go into chronicity? Hepatitis B and C are known to go into chronicity, which is common and potential. That I'll tell you in a while. Talking about carrier state. Again, for carrier state, I think we all know that hepatitis B is the most common to go into carrier state, and definition and all I'll tell you. So, overall I realized ones without an envelope are gastroenteritis wala. The only cultivable one is hepatitis A. The only one which does not have a vaccine is hepatitis C. Most common cause of fulminant is hepatitis D. Most common cause of fulminant in pregnancy is hepatitis E. The chronicity ones are B and C, and the carrier one is going to be hepatitis B. So gradually we will come on to this. Before I start off with all of them in detail, do you know there is something called hepatitis G also, which is not known to cause too much of a human infection, but whenever it enters into it doesn't cause infection, doesn't mean it cannot come in my body. It can come in my body, and it tends to affect the mononuclear cells. Single wala, like macrophages, lymphocytes, mononuclear cells. How does it come into the body? The route of transmission is going to be by blood transfusion. But they said that, okay, hepatitis as such it might not be causing. But now there are studies which are saying that if hepatitis G comes into the body, it gives an inverse protection against HIV. So that is another study that is being performed. But a lot of more studies need to be done on hepatitis G. I just wanted to touch upon the topic because you will see this written as 1 or 2 lines. So it is going to affect the mononuclear cells, comes in via the blood, and can give protection against HIV. Let's move forward. Abhi before going again, basics, sabka size yaad kar lo. So A, B, C keep on increasing. How I have learnt is that out of these, hepatitis A and E were the ones which were the gastroenteritis wala, na, so roughly same size, almost same size, 27 and 30 nanometers. Okay, so easy to learn. The ones which are associated with gastroenteritis are 27 and 30 nanometers. Then keep increasing. Hepatitis B is 42 nanometers and is also known as the Dane particle. The hepatitis B, which is 42 nanometers, is going to be the Dane particle. Hepatitis C, thoda aur bada, that is going to be 60 nanometers. So easy. A and E are going to be 27 and 30 respectively. B is 42 and C is going to be 60. Now we are finally ready to take on the world with the first hepatitis that we have, that is hepatitis A, which has an incubation period of what? Why should I learn like this? I will learn the incubation period like I had learned it for A and E. It was 15 to 50 days. That is why I've made it easier so that you can learn it that way. Fine. How many serotypes does it have? Hepatitis A has one serotype. There are 6 genotypes, out of which please remember that 1, 2 and 3 are the genotypes which are more commonly seen in humans. Out of which please remember, the first one is more commonly seen in the world and the third genotype is more commonly seen in India. These are all genotype. Dekho, serotype to ek hi hai, so whether it is in the world or India, it has to be just one. The concern is with genotypes. There are 6 genotypes. The first 3 are what is infective to humans. The first one is present all over the world and the third one is going to be common in India. Now, hepatitis A is susceptible to what? So, you can kill it by what all? You can kill it by boiling. You can kill it by chlorination, right? Chlorine can kill it. Autoclave can also kill it. And even formalin can kill it. So it's pretty susceptible to a lot of things. I can say it is heat susceptible because autoclave is killing it, boiling is also killing it, formalin and chlorine. These are the things used in a hospital. Now hospital mein kya karte? Ya to heat mein you do autoclave and boiling, chemicals mein you use chlorine and formalin. Hepatitis A is susceptible to all. And if it is a hepatitis, of course there is fever, anorexia, nausea, vomiting with jaundice. And we know jaundice matlab, how is the patient gonna come up to you? Dark urine and pale stools. There is nothing new that I'm telling you. This is all gastroenteritis wala features. Fever, anorexia, nausea, vomiting because fecal-oral route hai, nausea, vomiting hoga. And jaundice of course because it's affecting the liver. Okay, now moving forward, we know you are waiting for the lab diagnosis. So for the laboratory diagnosis, this is one of the easiest graphs that you have. You just have to look at 2-3 things. So the first thing to rise, can you see? The first thing to rise is the HAV, hepatitis A virus shedding. So remember that I can see symptoms over here. What symptoms? Symptom obviously ma'am jaundice hoga. So in the stools 2 weeks prior to 2 weeks after the jaundice, we are going to see hepatitis A virus in the stool. So please remember, if this is the jaundice that they have shown you, so 2 weeks before the onset of jaundice to 2 weeks after the onset of jaundice, you are going to see hepatitis A virus shedding in the stool. So fecal HAV is important. Okay, HAV dekhiye na, you have to see the antibodies IgM and IgG. As soon as the jaundice will start, you can see with the starting of jaundice, can you see that there is an increase in your IgM antibody, right? Everyone can notice as soon as the jaundice will start, there is going to be an increase in the IgM antibodies. And 2 to 4 weeks later, compare karo, where is IgG gonna start off? So approximately you will see 2 to 4 weeks later IgG is seen. So the levels start definitely rising, but thoda sa 2 weeks ka gap hota hai because IgM is primary immune response and IgG is gonna come up later. So simple. The primary question that comes is HAV is related. 2 weeks before the jaundice, 2 weeks after the jaundice. As soon as the jaundice will start, the antibody response is gonna be seen. Since I told you I will be correlating this with pathology, do you do a liver biopsy? No. These are acute hepatitis. Acute hepatitis ke liye liver biopsy not at all indicated. In fact, for hepatitis only, hepatitis is an infection. Why for an infection will I have a liver biopsy? Liver biopsy will be done for bigger things like cancers. So nahi karte. But still if they ask you that on a liver biopsy, the acute hepatitis, the 2 acute hepatitis, that is hepatitis A and C, which are going to spread by the fecal-oral route, if I ask you what are they going to be showing you on a liver biopsy, so remember, hepatitis A shows you an increase in the plasma cells and hepatitis E shows you cholestasis. Cholestasis means the bile is going to be static or slow. Bile plugs are seen. Again, no one will give you a picture, no one even does it, but theory, MCQ questions. Hepatitis A shows you plasma cells, hepatitis E shows you bile plugs, that is your patho integration. Finally, coming back to micro and medicine, is there a vaccine? Yes, there is a vaccine available and that vaccine is a formaldehyde inactivated vaccine given as an intramuscular dose. So please remember there have to be 2 doses that are given, which are roughly 6 to 12 months apart, and it is given to people who are aged above 12 months. So 12 months ka age gap ka duration between the 2 doses. So dose 1 and dose 2 with a gap of 6 to 12 months and the age is equal to above 12 months. That is when it is given. There is also another vaccine that is taken up in some countries which includes the live attenuated vaccine. This is made up of multiple strains like OH and OLA strain. Again, there are different vaccines being prepared which you have to know, but whom do you give immunoglobulins to? This is there for hepatitis A as well as hepatitis B. Immunoglobulin will always be given to someone who is not vaccinated and has undergone some kind of an exposure. So please remember that who has undergone some kind of an exposure and is unvaccinated, and especially, for example, someone in the house has hepatitis A and then someone is living with him and that person is unvaccinated. So to all the unvaccinated contacts, it has to be given within 2 weeks of exposure, and the protection will last for roughly 1 to 2 months. So remember, even if someone comes with hepatitis A, all the contacts who are unvaccinated, they have to be given immunoglobulins. Are we sorted with this? Hepatitis A ho gaya. On that note, I will quickly wanna also finish off, guys, hepatitis E. Why would I wanna finish it off? Because that is the one that is another feco-oral wala. So please note, in hepatitis E, everything I have told you. Which family belongs to RNA viruses? What is the family that you have? Earlier it was calciviridae, now it is hepiviridae. Feco-oral route, acute hepatitis hai, 15 to 50 days ka incubation period. It is the one A and E, they are non-enveloped. Can it be cultivable? No, the only cultivable one was A. Baki sab mein no. Is there a vaccine? Yes, there is a vaccine, although I would say that it's only in China. I'll talk to you about it. Is it a cause of fulminancy in pregnant women? Yes, it is. So please let me know now that when I'm talking about hepatitis E, what are the quick points that I can tell you? It is now belonging to the hepiviridae family, which belongs to the RNA family members. Let me tell you, in terms of the route, it is going to be a feco-oral route, and it is of course going to cause acute hepatitis, right? But in pregnant females, in pregnancy, the fulminant hepatitis rate is going to be a 25%. It causes fulminant hepatitis. Okay, what is the treatment? Like I told you, supportive treatment hoga. However, is there a vaccine available? Again, there is a vaccine available, but that vaccine is available in China, and that is a recombinant capsid vaccine. So for China, there is a recombinant capsid vaccine that is available. Capsid protein ka vaccine hota hai, that is available. Just some points about hepatitis E. I don't think anything new I told you. Everything I had already told you in that table. So table ko agar short note banao, to it is ready. The only thing I can tell you extra is there is a vaccine in China which is available. A and E are done. I'm going on to next, the chronic hepatitis. I'm starting with the most deadly and the awaited one, and that is hepatitis B. So let me tell you a little bit about genotype, serotype, and then I'll start with pathogenesis, structure and everything. Guys, over here, please remember there are 8 genotypes starting from A to H, whereas D genotype is the one that is prevalent in India. Question number 1. Which genotype is prevalent in India for hepatitis B? It is genotype D. Then there must be some serotypes also. Yes, you don't have to learn all. Neither do you have to learn north and south, east and west, but at least learn the names. AYW and ADR. These are the serotypes which you are finding in India. Repeating, AYW and ADR are the serotypes in India. D genotype is the one that is prevalent in India. Now we can go on to, let me take a quick test. Which family was this? This was Hepadnaviridae. So this means this was the only virus which was DNA, the only and only hepatitis virus which was a DNA virus. And my logic tells me that all DNA viruses are what? Single-stranded or double-stranded? All the DNA viruses are double-stranded. But yahan par ek catch hai. Yes, this is a double-stranded DNA virus. Correct. But there is a catch over here that it is a partial double-stranded DNA virus. So, pehle to you will say, ma'am, what is the double strand? Double strand means there is a minus strand and a plus strand. Plus strand can make the proteins forward, minus strand cannot. So there are 2 strands. Double stranded to hai. I can see over here very well that there is another strand and 2 strands. I can see na. But can you see one of them is totally complete, pura aisa round. The other one, it looks as if it is a part is missing over here, incomplete, exactly. So the minus strand is complete, the plus strand is incomplete. You don't know which is complete or incomplete, you don't have to know, you just have to know one of them is complete and one of them is incomplete. So is it correct to call it just a double-stranded DNA? No, ma'am, thoda sa part missing hai. This is a partial double-stranded DNA. So now I want to make a table for all of you because you have already done this in general virology. All the DNA viruses are double double-stranded DNA viruses. However, there was one exception जो पूरा ही single-stranded था. Which is the single-stranded DNA virus? Remember, Paro was left alone, so parvovirus was single-stranded. And which is the one that is going to be partially double-stranded? Now you know that hepatitis B is partially double-stranded. It has a chota sa missing strand. Now, we have done the andar ka DNA, but what about all the other things that are around it? So let me first tell you the names of it. It has certain genes. One is said to be the P gene, the C gene, the S gene and the X gene, and these will make the respective proteins which I'll keep labeling. So सबसे पहले P gene मतलब polymerase, and P is the largest of them all. So what did I say? This is the largest of them all, and P is gonna stand not. So they ask you कि P gene से क्या क्या बनेगा? DNA polymerase होगा. Also you have reverse transcriptase. You'll say why? Ma'am, reverse transcriptase activity is needed in RNA viruses. This is hepatitis B, DNA virus. Why in a DNA virus do you have a reverse transcriptase? Give me 5 minutes. You will realize this is very important. Apart from that, also RNAs. So remember the P gene, which everyone takes very lightly, it makes polymerase. No, it makes 3 things. This is a question that can come. The P gene makes 3 things. DNA polymerase understood, P for P, but it makes 2 R's also, the reverse transcriptase and the RNAs. Okay, so this dot over here was the P gene ka products, polymerase, RNAs, RT, all that. Now coming to C. C is what? C is said to be the core gene. It's said to be the core gene, and if you actually look at the structure of this core gene, you will realize not only does it have a core area, it also has a pre-core area. Not only a core area but also a pre-core area. That means the core area is going to code for the C antigen and the pre-core area is going to code for the E antigen. There are 2 antigens coming out of it. The core area is going to be the C and the pre-core area is going to be E. Finally, coming to S. S stands for surface antigen. S is going to stand for surface antigen. Let me show you an enlarged version of it, otherwise it won't make sense. Can you see these things which are coming out? That is of course going to be the surface antigen. How do I write it? I write it as HBsAg. However, I see that these surface antigens have different shapes or sizes, I can say, small, medium, large. If you look at these, they will have different sizes. They are small, medium and large, exactly. So please remember the surface antigen which you write as HBsAg, they can further be of small, medium and large variety. Finally, coming to HBx, remember HBx is the one that is responsible for carcinogenesis. Many people ask me that how does hepatitis, which cancer? Hepatitis, liver, of course. How does hepatitis cause hepatocellular carcinoma? It is going to be HBx. The reason for it is HBx. So jaldi se let's do a recap. What are the genes that it has? Sabse easy wala I can see on the surface. Let us do a recap from here. On the surface you have the S gene. That is going to make surface antigen, small, medium, large. Then you have a core. You have a core antigen, and core antigen actually makes 2 things. It makes core also, it makes pre-core also. After that you have the DNA polymerase, but again it not only makes polymerase, it makes 2 R's also, reverse transcriptase and RNAs. And finally you have an X protein that is hiding, and that X protein is responsible for something deadly, and that is cancer. ठीक है, यहाँ तक हो गया. Now my next question to you is, which out of all of these can I call as Australia antigen? So please note that this surface antigen over here has been given another name called as Australia antigen. This has been called as Australia antigen. So these 2 words become very, very important. The surface antigen is known as Australia antigen, and the next thing that they will ask you is what is Dane particle. So ये पूरा जो virus है, this full virus that I have taught you right now, this entire virus is known as, or hepatitis B virus, complete virus, no part missing, that is known as the Dane particle. Do not get confused between these terms, because now I'll tell you, if you feel that when someone gets infected with hepatitis B, this is all that is circulating in his blood. No, this is the complete wala form circulating in his blood. Do you know little bit parts of this are also circulating in the blood? So let me now teach you that yes, the complete Dane particle, what was the size of hepatitis B? 42 nanometers. So the complete or the full virus, the Dane particle means, ma'am, it has the genome also, the double-stranded DNA, everything that it has, pura infectious wala, yes, that is roaming around. But that is 42 nanometers. Uska kuch chota version is also roaming around. Some 22 nanometer things are also roaming around, which are known as spheres and filaments. They are parts of this. Basically what happens, I told you na, that this surface antigen can be made up of small, medium, large. So when I say that some small and medium wala strains are roaming around, I'll say they are like babies of this. Some babies are also roaming around. Babies are never going to be infectious. So please note that ये जो spheres and filaments होते हैं, which are almost half the size, 22 nanometers, since they don't have the genome, they are not going to cause the infection. So who is capable of causing infection? The full virus is capable of causing the infection. That is the DAN particle. Repeating, the DAN particle is capable of causing infection, and the size of it is 42 nanometers. Although you don't have to write it, but just listen it out once, that if I take the blood sample from a patient and I try to see na zyada kya hai, do these patients have more of full particles or do they have more of these chota parts? Babies are more. Trust me, these are more. These non-infectious things will be seen roaming around more, and the full particles are going to be much lesser. Finally, coming to mode of infection and pathogenesis. I think everyone knows parenteral, sexual, mother to child. I don't have to teach you that. Parenteral means blood products, of course, needle sticks, IV drug abusers, all of that also comes. Sexual intercourse, mother to child also. Percutaneous route is also known, and for us healthcare professionals, needle stick injury. Now, because we are studying it, to pura pad lo. Please note, when I'm talking about needle stick injury, I have learned it as blood stick injury. Okay, just for my mnemonic. What is blood stick injury? Because blood stick injury mein B is for hepatitis B, C is going to be for hepatitis C, and I is HIV. So I have written it as blood stick injury, BCI, because of hepatitis B transmission chances 30%, hepatitis C transmission chances 3%, and HIV transmission is 0.3%. Come, 110 you will keep on removing. That is why first you need to know the order. For needle stick injury, I have learned it as blood stick injury. 30%, 3%, 0.3%. Very famous question. I will also tell you the protocol after this for what happens after a needle stick injury. What are you supposed to do? So once this mode of infection has occurred, what is the pathogenesis going to be? That is very interesting. This is one of the most interesting and not so student friendly pathogenesis. We'll try to simplify it. The books have made it super complicated. We'll try to make it a little easier. Tell me something. This is a HBV, hepatitis B. So the first thing that you are going to say out to me over here is going to be that this is going to come inside. How is it going to come inside? It is going to come inside by a process known as, yes, endocytosis. So all of you can see that this has been engulfed, right? So basically it has entered the cell. Step number 1 is going to be entry. After entry, you say, I am not interested in all those layers. Remove them. Uncoating karo. I am interested in this DNA. Tell me, what kind of a DNA does it have? Does it have double-stranded? Yes, it does have a double-stranded DNA. But is it a complete double-stranded? No, it is a partial double-stranded. See, a part of it is broken also. Either dekho, a part of it is broken and a part of it is complete. The partial double-stranded DNA is there. My first thing is, whatever was left incomplete, please complete it. So the first thing that we make is cccDNA. What is cccDNA? Usse pura close karo. Please complete it. Covalently closed circular DNA. cccDNA is covalently closed circular DNA. If you don't want to learn it, at least learn that the incomplete portion is first completed. Pehle to complete DNA banao. From that, of course, you know, from DNA, guys, if translation occurs, what are you going to have? You will have the formation of RNA. What is that RNA known as? pgRNA. So you have made pre-genomic RNA. You have made RNA. You'll say, fine, ma'am, now from RNA, you have to make new viruses. So I'll say, okay, wait, hepatitis is a DNA virus. And now what you have at this point of time is, from this covalently closed circular DNA, ab to yaad hi ho gaya na, covalently closed circular DNA, you have made a pgRNA, and what have you done? You have made a nucleocapsid also around it. What a funny thing. This was a DNA virus. You made a mistake. You were supposed to make a DNA. You have enclosed an RNA by mistake. This is not a mistake. This is the pathogenesis. That is the question that you asked. That initially what happens is that the capsid is made around what? The capsid is made around pre-genomic RNA. So you will say, ऐसे तो नहीं चलेगा, this is not an RNA virus, please change it into DNA. How do you change an RNA to DNA? If I have to change an RNA into DNA, what enzyme will I use? I will use reverse transcriptase, and that's the catch. Remember, I told you something called a P gene, and I kept on saying that everyone says, "Arey, P gene is DNA polymerase, but it will also have reverse transcriptase activity." And you were wondering, where will I use reverse transcriptase? Here it is. यहाँ पे थोड़ा सा गलती हुआ. There's a mistake. By mistake, you ended up enclosing an RNA. First, you'll have to change it into a DNA. You know how do you change it into a DNA? By a reverse transcriptase. But this DNA is which strand? Ma'am, there were two strands, minus wala, plus wala. So the first thing that is formed is a minus strand DNA is formed. ठीक है. Now after minus strand DNA, you will have to make a plus strand DNA. So you will have to make the second one, जो plus strand वाला, जो second वाला है, that is made how? That is made by DNA polymerase. Now you know how all those enzymes are being utilized. So nice. So repeating, you ended up enclosing an RNA. So then you said, never mind, once a mistake is done, I will rectify it. I will first make a minus strand DNA with the help of reverse transcriptase. Then I will make a P for P. I will make a plus strand DNA with the help of DNA polymerase. And finally, itna kuch banaya, I need to assemble it and make it one virus. And that is going to happen in the endoplasmic reticulum. So I'm going to make one whole virus, and finally I am going to release it out. That is how this is different. Everything. What are the key factors where they'll ask you? Sabse pehle, what is the DNA? Partial. So I will have to close it. Covalently close circular DNA. Then I make what RNA? I make pgRNA. By mistake, I enclose it in a capsule. Then I rectify my mistake. I make a minus strand of DNA with reverse transcriptase, plus strand of DNA with DNA polymerase. Sab kuch ek saath jodo in the endoplasmic reticulum and release it out. I hope everyone's okay with this set of information. Very important pathogenesis that they are going to ask you. Now that you've done this pathogenesis, I'm going to take you to the most important, and that is lab diagnosis. I know this graph is something which is very, very scary for you. I will tell you every part of it. Then I will make a final table and a mnemonic of how to learn it. So, sabse, if pehle I ask you, look at this and read this question carefully. The first virological marker that comes out in the blood, and everyone jumps to the answer of hepatitis B surface antigen, because that is what I saw, ma'am. But no, I did not ask you the first antigen to come in the blood. I asked you what is the first marker to come in the blood, and that is the DNA. If HBV DNA is there in the option and they ask you which is the first marker to come in the blood, HBV DNA, of course. But if they ask you the first antigen to come into the blood, yes, I can see that it is the hepatitis B surface antigen, and I need to correlate that with the help of symptoms. I can see symptoms matlab why jaundice, na, yellowish jaundice. So remember, it appears 2 to 6 weeks before the onset of symptoms. That is why it's the first antigen to be there, and you can very well see 1 to 2 months after the onset of jaundice. So agar yahan pe dekhen, this is somewhere coming around the 4th week. And symptoms are somewhere coming around the 10th week, if I can say so. So, is wale case mein. So, somewhere between 2 to 6 weeks before the onset of the symptoms, it's gonna come up, and 1 to 2 months after the symptoms, it's gonna stay. So, I realize if I start tracing hepatitis B surface antigen and the symptoms are over, it is still there. You'll say, ma'am, once the antigen is gone, the antibody should come, hai na? Bilkul, the antibody comes next. But when the antibody comes, this is anti-HBs antibody, bilkul. If this is present, this means I will say this is an epidemiological marker. I will say the person is in a stage of recovery. However, do you see there is a gap between the ending of the antigen and between the starting of the antibody? There is a gap. Imagine if my patient would have come in this stage and I would have done a blood test, neither would have the antigen come positive nor would have the antibody come positive, and then I would have told the patient that you are to hepatitis negative. Is a window created over here? Yes, antigen has gone off and antibody is coming after some time. So there's a gap, a window created. How will I test? How will I find out if someone is positive in this window? This is window period. I will tell you in a while how we do that. But abhi ke liye, what are the 3 points? Hepatitis B is the first to appear. So if I ask you, who tells you the onset of infectivity? Which antigen tells you the onset of infectivity? Hepatitis B surface antigen. 2 to 6 weeks before jaundice till 2 months after jaundice. When it will end, a gap hoga, then the antibody will come. Okay. After this, if you look, hepatitis surface is done, shortly after it, hepatitis E is coming out. What was hepatitis E, if you remember? Pre-core antigen. So I can see now hepatitis surface yahan tha. Shortly after it, I can see that HBE is also coming up. So it appears shortly after HBS. What does it indicate? HBE tells you, oh my god, infection. It tells you the load. Basically, it tells you the infectivity rate. So not everyone will be HBE positive. If HBE comes out to be, antigen comes out to be positive, that basically means that the patient has high infectivity. And this means that once this antigen will go off and its antibody will start off, you will say, oh, this means now the infectivity is going down. When I say that the antibody has come, that will mean that the infectivity has gone down. Samajh aa gaya? So till the time the antigen is there, highly infective patient, once the antibodies will come out, this means the infectivity has gone down. So kya antigen ho gaya? The first one was surface to come, S comes first, after that E comes. What are you expecting next? Ma'am, ab bacha kya? S done, E done, C is the next one. So where is the core? Tell me something, the name of HBC antigen, which is core antigen, don't you feel it is stuck in the core? The virus का जो core है, this C antigen is stuck in the core. Will it be able to come out? No. Remember, this is the only antigen which is not detected in blood. That is the catch. This is not detected. See, it's there in your body. It has entered into your liver cells, but it is not going to be present in the blood because it's stuck in the core. See, antigen did not come out into the blood. But are you exposed to it? Are you going to make antibodies? Of course. Anti-HBC antibodies though I will make because it's sitting in my body, so I have to respond to it. Which antibodies do I have? IgM and IgG. So let me start tracing it. I see over here, look at the red wala line. I can see the red wala line and how this IgM anti-HBC is covering a very essential part of my life. If you remember, I was telling you one problem that, patients may surface antigen goes away and antibody comes very late. There is a gap present. There is a window period present. Who is still covering that window period? Is this antibody. Who is the marker of the window period? The IgM anti-HBC antibody. IgM type of anti-HBC antibody is doing that work for me. It is covering the window period that I had. So over here, I had no one to help me. Now I have someone. After this, of course, IgM ke baad, of course, what is going to be there is going to be IgG. So that's the next antibody in the long term. But remember, IgM as a marker of window period is very, very important. Okay, now you have, what all have you done? If I give you a very quick brief, first was surface antigen. Then along with it, HBE antigen can come. Then there can be anti-IgM type of anti-HBC. Then of course later on you're gonna have the anti-HBE and the HBS and SARA antibodies will come. So now if I ask you an answer to all of these questions, let's see if you can do this. Tell me, what will you say is acute hepatitis B? What all is going to be acute hepatitis B? So you will say, ma'am, everyone, first thing to rise, if you're saying hepatitis, the first thing to rise has to be HBS, definitely. After that, acute bol rahe ho, to abhi obviously the antibody has not come. HBS ke baad कौन आता है? S के बाद E आता है, तो of course ma'am HBE antigen has to be there. Then the IgM antibody comes, IgM anti-HBC, and that is what known as acute hepatitis. What is SEMA? SEMA tells me that in cases of acute hepatitis, you have SEMA. SEMA मतलब SEMA, surface antigen होगा, HBE antigen होगा, and which antibody? IgM type of anti-HBC will be present. That is what you will call acute hepatitis. This acute hepatitis is low infectivity or high infectivity. Who tells you infectivity? Hepatitis E antigen tells you infectivity. If hepatitis E antigen is there, this means it is high infectivity. Okay, then what is chronic hepatitis B with high infectivity? You will say, ma'am, again hepatitis hai to S to hoga, high infectivity hai to E bhi hoga, but this time you are saying chronic. If you are saying chronic, I will change this IgM into IgG. So what is the profile? What is the profile gonna be now? So I will say surface, yes, it's there. High infectivity hai E, yes, it's there. But because it's chronic hepatitis, instead of IgM, I will write IgG type of anti-HBC. Is life becoming a little simpler? सीमा याद कर लिया for acute hepatitis. Chronic के लिए just change the M into a G and that becomes chronic hepatitis. In any of these, if I don't keep E in it, it will become low infectivity. You know that. Finally, let's talk about recovery. If a person is recovering, recovery का क्या definition होता है? Antibody, antibody, antibody. If a person is in recovery phase, that means anti-HBS, anti-HBC, anti-HBE. Recovery matlab all the antibodies are gonna be there. Next, what is the window period? Ma'am, window period was the time when no one was helping you. Window period was the time when no one was helping you except one person. What is the marker of the window period? The marker of the window period is IgM type of anti-HB, anti-HBC. Okay? Finally, immunity. If someone has been given a vaccine, because the vaccine is to do with surface antigen, where vaccine ka jo preparation hota, that is surface antigen, so the antibodies formed are always anti-HBS. So if a person has been vaccinated, it is only anti-HBS that the person is gonna show. So I'll do a very quick recap. सीमा हुआ तो acute hepatitis with high infectivity, M replaced by G, so that means that is chronic hepatitis. Recovery matlab all antibodies, immunity matlab only anti-HBS, and window period is anti-HBC of the IgM type. However, we're forgetting one thing. What if hepatitis B infection happens in a pregnant lady? How are you going to deal with that? And what vaccine are you talking about? So if hepatitis occurs in a pregnant lady, you have to look out for what actually you know. Hepatitis to pata lag jayega. You have to find out, does she have a high infectivity wala hepatitis or not? How do I know out infectivity? HBE. If the mother has high infectivity wala hepatitis, means if HBE antigen is positive, then the chance of transmission is very high, 90%. But if she has in that phase had an antibody, HBE antibody is present, then at that stage the risk of transmission is only a 10 to 15%. So simple, if infectivity antigen is there, more risk of transmission. If the antibody has developed, less risk of transmission. Either ways, whenever a neonate is born to a mother with hepatitis B, what do? On one arm you put vaccine, on one arm you put immunoglobulin. So on one arm you're going to put immunoglobulin, on other arm you put hepatitis B vaccine. I think everyone as a healthcare professional knows the hepatitis B vaccine ka dosage is or scheduling is 0, 1 month, 6 months. So 0 dose, 1 month and 6 months. So now that when you're talking about the vaccine, I think we all know that hepatitis B vaccine ka schedule to we have done. It is 0, 1 month, 6 month. This is prepared in a yeast. If you still want to know which yeast, Saccharomyces cerevisiae. This is prepared in Saccharomyces cerevisiae wala fungus or yeast, and it is a recombinant killed vaccine 016. Every time you have gone in for this, you have taken the 016 wala dosage. However, what I'm also going to tell you, what is important, you are a healthcare worker and needle stick injury is something you should be knowing even before taking admission into MBBS. Unfortunately, we don't even know about it after clearing MBBS. But that is safety. Our safety comes first. So first and foremost, all of us have been vaccinated in our childhood. So ideally, what is the antibody titer that we should be having? Anyone who has already been vaccinated should have an antibody titer of anti-HBS more than 10 international units per ml. On that note, let's consider someone who's had a needle stick injury, and I've got you the latest guidelines because not just everything is not about MCQs or exams. Some things are about self precautions, right? So what happens following a needle stick injury? You need to find out what is your status and what is that patient's, just say needle prick hua hai, what is his status. So you need to know the status of your source, whosoever was that needle wala person, and you need to know healthcare worker. You need to know your own status. So for example, if you are by chance, if you are unvaccinated, although I don't come across such people, but you could have people elsewhere also, not only hospital workers don't get needle pricks. There are so many people who have IV drug abusers and otherwise also, they can get a needle prick and they come to you and say that we are unvaccinated. So kya karoge? And they then, okay, their status to you know, they are not vaccinated. Then you will ask me, needle prick kiska hua? Do you know that that person is HBV positive or negative? or not known. So there are three possibilities. If the person is definitely HBsAg positive and your healthcare worker is also unvaccinated, मतलब उसे hepatitis है और इसके पास vaccine भी नहीं था, you will have to do everything. You will have to give immunoglobulin also, plus you will have to do 016 ka vaccine also. You will have to do everything in this person undoubtedly. If the person is proven hepatitis B negative, then you are just gonna do 016. Just start the vaccine of this person because this person was not vaccinated, तो उसका vaccine शुरू कर दो. Even if the source is not known, you still go in for 016 and that is you start with vaccine. The basic concept is that this person is not vaccinated. So in all the cases, your primary concern is pehle to give him a vaccine. But if your source was known, you have to take extra precaution. You also give him immunoglobulin. Sorted? Okay. Coming to the next, which is most commonly what you guys will see. I mean, God forbid you may never have a needle prick injury, but it's such a common thing that everyone ends up having one in their lifetime. I also had one during my first year residency, MD. Okay, so next is if you are vaccinated, which most of us are, you first need to know whether you are a responder or a non-responder. How will you find out? Based on your antibody titer. If you are vaccinated, if your antibody titer is more than 10, you have responded. If it is less than 10 or in 0, like in my case I'm sharing with you, when I had a needle prick injury, my antibodies came down to be less than 10. I don't know why, although I know I was vaccinated in my childhood, but there are 4% of people who don't make antibodies. That is when I sat and read about it. So I came under the non-responder category. So remember, either you can be vaccinated and a responder or vaccinated and a non-responder. So what are you going to do? See, if you are vaccinated, very good. And if you are a responder also, very, very good. Then they say that ideally you don't have to do anything. Then they say that ideally you don't have to do anything. But if you are vaccinated, like I'm sharing my case with you, I was vaccinated, but I did not respond. So now we had to look at the patient over here, look at the source of it. So if you are vaccinated, तो नाम का vaccine है, response तो नहीं है ना. So it is almost equivalent to an unvaccinated person. Injection तो लगा, but your body did not respond. So what are you going to do? Ma'am, you'll take full everything. You will take immunoglobulin also and you will take 016 vaccine also, and that is what I did. Because unfortunately, when I got a needle prick injury, I was vaccinated and I was at least happy that chalo, I'm vaccinated. But what was the bad news was that when I got my blood test done, I turned out to be a non-responder, that is less than 10 international unit scale. And what was even worse was that then I got to know later on that my patient was also hepatitis B positive. So I had to go in for this entire protocol. I got an immunoglobulin, same day I got the first dose of the vaccine, and then I continued this, and thankfully with God's grace, nothing happened. Okay, what if your source is negative? So you are vaccinated, na? ठीक है. Don't do anything, and if the source is unknown, don't do anything. Although here they say there are a lot of things which are getting a little, changed. They say that people who want to be on the precautionary side, they can take immunoglobulins, even if the source is not known. These two categories, people are a little, and even I would have been a little scared about it. That I am a non-responder anyway, so why take a risk and why not take the precautionary dose? So that depends from hospital to hospital, but this is the basic thing. So simple. If you are unvaccinated and you get a needle prick injury, so you should know if you are unvaccinated, ek to pehle vaccine lagwa lo abhi se. But if you are unvaccinated, anything anytime happens, vaccine you will always have to take 016. Additionally, you will take immunoglobulin if your source turns out to be positive. If you are vaccinated and a responder, you are the safest person on this planet. Again, some people still take it up for precautionary measures. Okay, now finally, there are going to be some variations. Ye sab to ho gaya. But what do you call as a person who's a carrier? Who is a carrier? Because I told you, hepatitis B was the one that had a 30% carrier state. Okay, when the surface antigen is positive beyond 6 months, that is the definition of a carrier. Surface antigen positive beyond 6 months is a carrier. So simple carrier or super carrier. Simple carrier, super carrier ka definition is same. Surface antigen beyond 6 months is carrier. What is the difference between simple versus super? So imagine super will be super duper infective. Super duper infective means HBe antigen is also positive. and the DNA polymerase is also there. The liver enzymes are also increased. That is why he's super duper. E bhi hai, DNA polymerase bhi hai, enzymes are also elevated. Simple is just simple. Keep life simple. Simple definition. HbS is positive beyond 6 months. That's about it. Not HbE, and DNA polymerase levels are also very low. Simple, तो simple वाले में सिर्फ simple HbS रखना. Super duper में HbE also, DNAP also, liver enzymes, everything goes up. Now moving forward and talking about some variants. So right now I was telling you there is a surface antigen, there is an HbE antigen, but now you know viruses are mutating. So what if there is someone who is said to be an escape mutant? So now let's go on to discuss a few mutations, because we all know that viruses are much prone to mutation. So let's take the first one that we have, and these are going to be the escape mutants. What are escape mutants? The ones which don't have a surface antigen. So what is the problem with them? The problem is that all of us have one point of time been vaccinated with hepatitis B. This means all of us have anti-HBs antibodies in our system. And the reason that we've got them in our system is that if a hepatitis virus tries to enter us, those antibodies are able to neutralize it. But if this hepatitis B virus enters, which doesn't have a surface antigen, it is a hepatitis, it is going to cause infection, it's just trying to be an escape, it's not showing that antigen only. So will this be able to neutralize it? No. Remember, this will not be able to neutralize the escape mutant. Our protective antibodies will not be able to neutralize the escape mutant. That is what is important. This is one thing. The second mutant that we have is a pre-core mutant. It's telling you pre-core was HbE antigen. If the HbE antigen is absent, that becomes a pre-core mutant. And please note, in such patients, infection to kaise pata lagega high infectivity is there or not? You will measure the DNA copies. DNA copies more than 1000 is going to be indicative of infection present. That marks the end for all of you for hepatitis B. And out of this, just one word that I want to tell you from point of view of healthcare workers, that nowadays a lot of healthcare workers are actually showing you these kind of escape mutants, because staying in the hospital and getting exposed to so many things is resulting in mutations. So escape mutants is becoming common in hospital or healthcare workers. There is one virus which is dependent on hepatitis B, and that is hepatitis D. D is basically defective. I'm not repeating that entire table, the family, the carrier, all of that we know. We know this was also one of the most common causes of fulminant hepatitis, right? We already know. I'm going to tell you something extra. There is something called a co-infection and a super-infection. So this is kind of understood. Co-infection matlab saath-saath. B and D are going to occur together. Super infection will mean one on top of the other. So remember, if hepatitis B and D infection occurs together, that is known as co-infection, and this is usually going to clear off. But which scenario is it going to be very deadly? In case of IV drug abusers. So this is something which you very commonly also see in IV drug abusers, and over there it is going to be resulting in a co-infection. So that is when I will say it can result in fulminancy. That is when I can say it can result in fulminancy. Otherwise, I'm saying that it is not the one that is going to result in fulminancy. It can clear off quite easily, but in IV drug abusers, it can cause fulminancy. Whereas what is a super infection? The person already had HBV, B was there, and super on top of it, he got infected with HDV. So basically, HDV has done a rule, hepatitis D, that HBV should be there. Either I will go with HBV, or wherever HBV is sitting, I will go and sit over there. So I will go as co-infection, or I will go as super infection. Yes, super infection causes fulminancy, but co-infection can cause fulminancy in which scenario? In IV drug abusers. So this is the most common cause of fulminant hepatitis. But fulminant hepatitis in pregnancy, I have told you, is caused by hepatitis E. Okay, so this was about hepatitis D. Again, nothing much known. We all know it is non-cultivable. We all know that table, so that remains as it is. Now we move on to the last one, and that is going to be hepatitis C. What is it about it? It is one of the mutable viruses. That is why. Now I'm going to tell you something. Highly mutable virus. It is constantly mutating. So how should I make a vaccine against it? Ma'am, by the time I pick up one strain and I make a vaccine against it, it has already mutated and another strain has come out. So how should I make a vaccine? The most mutable protein out of them is going to be E2. So remember, highly mutable, most mutable is E2, and this is not going to help in vaccine production, and that is going to be known as quasi-species. What is quasi-species? I always used to joke about this on my Telegram group. I still do. You must have seen on Telegram there are a lot of students who are constantly trying to promote some codes and some app codes that are there. So there are Autobot settings on the group which tends to ban anyone who's trying to illegally sell or purchase these accounts. So by the time the group used to delete one of them, they used to come up with a new username and come up with a new account. Then the group used to delete them. Then again they used to come up with a new username and a new account. So that I always used to say, these are quasi-species. These people are quasi-species, that by the time you decide that I will make antibodies against this virus, that virus has only changed. The next strain comes, you say, okay, by the time I will make antibodies against it, again the virus has changed, and that is quasi-species. So it doesn't have a definition, but this Telegram user thing which I have told you, which all of you have seen, will definitely be relatable, right? That is known as quasi-species. How does it spread? Very important. One of the most important spreads are parenteral. Parenteral means IV drug abuse as well as blood transfusions. Parenteral route is very common. How do you do the lab diagnosis? Look at the virus, look at the antibody, nothing fancy about it. So which antibody am I talking about? IgM type of antibody. There is a card testing. We all know na, hepatitis B ka, C ka, sabka ek card testing hota hai. So for this there is an HBC tridot, which is nothing but HCV tridot, which is nothing but a kind of a card testing which you have. And finally the diagnosis of choice will always be the HCV RNA. Nothing can beat that. So this is not drug of choice, this is diagnosis of choice. Diagnosis of choice will always be measuring the RNA PCR directly, but yeah, in the absence you can do antibody testing. Okay, all of this is done. Now micro part is over. Nothing more in micro. Patho part comes now. What is it that you will see under the microscope? Firstly, you will say, why are you seeing something under the microscope, ma'am? Should you be seeing acute and chronic hepatitis under the microscope? Ideally, no. But still, I'm going to tell you. Okay? So, what are you going to see? In case of acute hepatitis, I think everyone is already aware that there are some bodies that you see in acute hepatitis, and those are known as the Councilman bodies, especially with which hepatitis? The starting stage of hepatitis C. Okay, so these are the Councilman bodies. You have seen this before in pathology also. Councilman bodies are nothing but the apoptotic bodies. And how are they going to look like? What are the three features of apoptotic bodies that you have? Chota cell. There is cellular shrinkage that you see. And when you look at the cytoplasm, there is very, very pink cytoplasm. And if you look at the nucleus, there is a very, very blue nucleus that you will find. Let us label it. Look at the cell. Look at the cell. Look at any normal cell. Pehle, ma'am, let's look at this is a hepatocyte. It's pretty big. If I compare this Councilman body, what has happened to the size? The size has become chota. Look at the color of the cytoplasm, very, very pink. Compare karo, very, very pink. Look at the color of the nucleus. The nucleus has also become very, very blue. So every color is becoming more of pink, more of blue, and the size is becoming less. That is an apoptotic body known as Councilman body. Other than that, damage to shuru ho gaya. Damage has started. So there is spotty and dropout necrosis. Little hepatocytes have started, getting necrosed. So spotty necrosis, and necrotic cells will ultimately die out. So that will be known as dropout necrosis. So spotty and dropout necrosis are seen. So now there are apoptotic bodies being formed, necrotic bodies being formed. So much of death happening. Who is the cell which is suddenly going to say, oh wow, so much of food, let me go and eat it? Macrophage. What is macrophage in the liver known as? Kupffer cell hyperplasia. So what are the findings? Councilman bodies, lot of spotty and dropout necrosis, and the macrophage has got a feast of food around it. So Kupffer cell hyperplasia, nothing but macrophages. Whereas what happens, this was all acute hepatitis. Acute hepatitis mein ek aur cheez batao that I've taught you. Acute hepatitis also has which two main feco-oral wala? Hepatitis A and hepatitis E. I think I've already told you that hepatitis A is going to show you an increase in the plasma cells, and hepatitis B is going to show you cholestasis or bile plugging, right? This we've already studied. Now let's come to something converting into chronic hepatitis. Chronic hepatitis ka matlab there is going to be fibrosis. Which is the most fibrogenic cytokine? Fibrogenic cytokine is always TGF-beta. Which cell of the liver releases this fibrotic mediators? Ito cells. Ito cells का दूसरा नाम stellate cells. So actually it's the stellate cells which release these mediators. And where are stellate cells present? They are present in the space of Dc. If you are aware of all of this, very good. If you say, ma'am, I don't know what you're talking about, Ito, stellate, space of Dc, these are Greek words to me. Pick up the liver chapter. Maybe you've not read pathology as of now. Pick up the liver chapter. If it's not in your agenda, never mind. Listen to the first 7 minutes of that chapter. Bus. Because over there, all the normal of liver is discussed. After that, you can read it whenever you want to. But the first 7 to 8 minutes of that chapter is enough for you to understand. So there's a space called space of Dc. In that space, normally we have these cells called Ito or stellate cells. Stellate cells release these mediators called TGF-beta. TGF-beta in pathology I've taught you, बहुत fibrosis. TGF-beta causes बहुत fibrosis. That is going to result in fibrosis and that will result in chronic hepatitis. So which were the two ones which were main ones for chronic hepatitis? Hepatitis B, hepatitis C. तो अलग से पढ़ लेते हैं ना. When I'm saying chronic hepatitis, primarily I'm saying hepatitis B and hepatitis C. So let me look at them under the microscope. Hepatitis B, remember it had an antigen called HBsAg, Australia antigen, yes? So first you'll say, ma'am, pehle to tell me, can you look at it on a pink and blue slide and find out that maybe HBs antigen is there? Yes. We see ground glass hepatocytes. Can you all see there are these big cells which are diffusely pink? Ground glass hepatocytes are extremely pink cells and they are indicative of hepatitis B surface antigen being present. I say, you say, ma'am, I don't trust you. Everything looks pink. Ab ye bhi pink hai. Prove it. Pathology mein to sab kuch pink hai. What is the pink stain? What is the stain that you can use? We have something called the Orsin-Shikata stain. Positivity. Hepatitis B surface antigen is Orsin-Shikata stain. Positivity. Very important. That is what you have for hepatitis B, ground glass hepatocytes. What do you have for hepatitis C? You have fatty liver and lots of lymphocytes. Fatty liver and lots of lymphocytes. Fatty liver kaun sa wala? Not chota wala. Fatty liver, big vesicles. Have a look at this picture. This is a picture of hepatitis C. Can you see big white spaces? Okay, ma'am, there is fatty liver. That too big vesicles. Macrovesicular steatosis of fatty liver is seen. And I can see some blue aggregates. This means I see the presence of lymphoid follicles. That is indicative of hepatitis C. So you will also ask me, ke big fat dikha to hepatitis C. But ma'am, you had taught us also that chota fat dikha to little fat is seen. So that little wala, that is hepatitis D. Now I want to tell you that hepatitis D is sab kuch little. Why do I say sab kuch little? Because I will remind you. Do you remember reading general virology and I asked you who has the smallest genome? The smallest genome was of this poor hepatitis D. Tabhi to khud se he can't do anything. He's always relying on hepatitis B. He has the smallest genome. Now I need to know that the same hepatitis D, which hepatitis shows you microvesicular fatty liver or steatosis, also hepatitis D. So bichara chota sa genome, chota fat, and that is what is going to be hepatitis D. Let's do a recap. When I'm saying chronic hepatitis B shows you ground glass hepatocytes, hepatitis C shows you big fat and big lymphoid. Hepatitis D shows you chota genome and chota fat. So you will say, ma'am, so much information of patho you've told us, full integration done. But the first line you said was कि biopsy करना ही नहीं है. You don't have to do a biopsy in a liver hepatitis case. Sometimes you have to. What is the indication of biopsy of the liver? Not in acute, but in chronic hepatitis for staging and grading. Please remember, in chronic hepatitis, when you have to do grading and staging of the hepatitis, that is when you do liver biopsy. So what are the features? Staging is based on how much of fibrosis has occurred and grading is based on how much of inflammation and necrosis has occurred. कैसे याद करें? एक side, learn one side. Grading is based on inflammation and necrosis. So this is a word that everyone will remember, right? So when we say GIN, please remember grading is based on inflammation and necrosis, and then staging automatically becomes based on fibrosis. This is the indication of a liver biopsy in hepatitis. Otherwise, there is no indication. Okay. Now I had promised you, hepatitis done. I had promised you that right in the end, we will make one full table where we will study all of these. Yes, remember this? Let us start. If I ask you which is the acute, देखो acute hepatitis, you said ma'am या तो hepatitis A है या E है. So the most common cause of sporadic acute hepatitis in India is actually hepatitis E, Harrison. The most common cause of sporadic acute hepatitis in India, hepatitis E. Now let's come to the hepatitis which is fulminant, and I've taught you. If I would have just asked you fulminant, danger, so ma'am सब कुछ तो छोटा छोटा था about it, small genome, small fatty liver, microvesicular, but छोटा packet and बड़ा धमाका. It is gonna cause fulminant viral hepatitis, that is hepatitis D. But if I convert it into fulminant viral hepatitis in pregnancy, now I know that is going to be hepatitis E. तो ये वाला part तो I already knew. Now let's move forward. Which is the most common transfusion related hepatitis? So blood transfusion से hepatitis B also happens and C also happens. But if I look at the prevalence wise more, hepatitis B is more prevalent. So transfusion related, it is going to be hepatitis B. Similarly, if I ask you chronic hepatitis, most common cause of chronic hepatitis, you will say, ma'am, going by prevalence, if you ask me most common cause, hepatitis B is always more common. But who has a greater potential of chronicity? There's a difference. See, most common cause is based on the number of cases and the prevalence. The most common cause of chronic hepatitis is hepatitis B. But who has a greater risk of converting to chronicity? That is going to be hepatitis C. Also, what is the most common cause of carrier state? Hepatitis B. What is the most common cause of hepatocellular carcinoma? Hepatitis B. But if I suddenly say which has the strongest association with hepatocellular carcinoma, that is hepatitis C. So overall, the easier way of learning this table is, देखो यहाँ तक तो table वैसे ही आता. Acute hepatitis, hepatitis C, fulminant, hepatitis D, but fulminant in pregnancy, hepatitis E. Till here the table was simple. Now whenever someone asks you most common cause of transfusion related, most common cause of chronic hepatitis, most common cause of carrier state, most common cause of viral induced cancer, सबका answer is hepatitis B, because hepatitis B somewhere in prevalence is only more. But if I now ask you the maximum risk and potential of chronicity, the maximum risk and potential of chronicity is HCV, and the strongest association with hepatocellular carcinoma, HCV. Everyone's understood how to simplify this table? Good. Finally, the last table is other than hepatic, what are the extra hepatic manifestations that especially hepatitis B and hepatitis C have taught you in medicine, in path, in micro, everywhere. This is an integrated class, right? You must have heard in pathology, I taught you polyarthritis nodosa, the blood vessel problem, that is HbSAg positive in 30% cases. Padha hai? In kidney, I have taught you membranoglomerulonephropathy. Membranous glomerulonephropathy also is hepatitis B, also is hepatitis C. ये B and C दोनों के साथ है. Hepatitis C में the most common finding that you have to know is mixed cryoglobulinemia, very famous. In kidney, they ask you MPGN. And skin mein, you know, lichen planus is associated with hepatitis C. Let me ask you one question from dermatology. Lichen planus shows you which bodies? Yes, which bodies? Colloid bodies. Colloid bodies C se hota hai. Hepatitis C wala hai. So lichen planus is colloid bodies and associated with hepatitis C. Finally, MPGN is also there. But the most common kidney manifestation asked, if at all, in hepatitis C, it is mixed cryoglobulinemia. And that marks the end of this entire chapter. It's been quite a lengthy chapter, but you know it's important because I've integrated path micro both. So you can just copy paste it over there as well. Thank you.